Sorry.
Hello, and good afternoon to everyone. And I'd like to welcome you to the Lessons in Bronchiectasis webinar series. My name is Michal Steinberg. I'm a pulmonologist from Haifa, Israel, and the coordinator of this series about bronchiectasis, webinars about bronchiectasis. Today's topic is the microbiology of stable bronchiectasis. And our presenter today is my colleague from my center in Carmel, in Haifa, Dr. Raya Cohen, who's a pulmonologist, specializing in bronchiectasis, including tuberculosis and non-tuberculous mycobacteria. And we have a guest discussant today. This is Dr. Grogono. She's a respiratory consultant from Cambridge Hospital in the UK, and we're very delighted that she's joining us to discuss this topic. You will see on the screen that there's instructions for Zoom translation for those of you who need it. To activate it, you click on the show captions and then right-click, open a menu with choosing the target language and the speaking language, leave it please in English as it is. Welcome everyone again, and Raya, please go ahead. And please, can I remind everyone, sorry, to be as active as you can, placing comments and questions in the chat. And we'll have a few polls, so please help us with trying to answer it either in the chat or as choosing the right comment in the Q&A. So I'm done talking, so please, Raya, go ahead.
Okay, thank you, Micha. Thank you for the presentation. Good afternoon, everyone, and thank you for the opportunity and invitation to do this talk. My talk will be divided to 3 parts. We'll talk shortly about general concepts regarding microbiology of the lungs, microbiome, the definition of microbiome. We'll also talk about specific pathogens in bronchiectasis. And at the end, we'll talk about interventions regarding the microbiology of stable bronchiectasis. So first, I'd like to start with a question. And the answer is free writing, so please feel very free to write whatever comes to your mind. And the question is, how do you understand or define microbiome? And it's really to stimulate our thoughts now about the subject, so please feel very free to answer anything that comes up to your mind, and you can write the answers in the chat box or the Q&A.
So there are really no wrong answers.
Comments?
So we would like to see some comments here.
Don't be shy, you can just write anything. Okay.
Well, so I think there aren't any comments coming up that I can see, and what I don't want to do is take away from what Raya's going to discuss with us. But I guess what we're looking at in terms of microbiome is all the different kind of organisms that you can find inside the lung, and just trying to have a kind of deeper understanding, perhaps, of what we're talking about when we're talking about organisms in the lung. But I think, Raya, shall we let you carry on with your presentation, and you can
thank you. I'll carry on. And well, I hope anyway that it helped you to start thinking about the subject. So first of all, I'd like to say a word about the changing concept of lung microbiome in the last few decades. So in early years, strangely enough, researchers and doctors believed that the lung to be sterile. But in the last few decades, we understood that the lung is not sterile at all. The microbiome may not be as abundant as other parts of the body, such as the gut or upper airways, but definitely it's not sterile. In the last 2.5 decades, there have been a lot of research into lung diseases that are related to infections, such as CF, such as pneumonia, of course, bronchial diseases, COPD. And lately, we've also started to understand that the microbiome also has a role in lung diseases that are not considered infectious, such as fibrotic lung diseases and even lung cancer. So the lung microbiome has become a very important topic for research in recent years, and is developing more and more. So what is the microbiome and how can we test it? So we will talk about the definition of microbiome, testing microbiome in general, and testing lung microbiome specifically. So when we think about the concept of microbiome, there has been a huge change together with the changes in technology, in our ability to look at microorganisms and discoveries that these technologies have helped us make. So if 350 years ago was the first time we saw microorganisms due to the development of microscopy, and the first concept was of a single microorganism, a bad microorganism that causes disease. In the following years, other technologies have developed. For example, humans were able to culture microorganisms and see many more microorganisms in each sample. So we understood more about interactions and communities of microorganisms. And in the last 50 or 70 years since the discovery of DNA, our abilities have even grown much, much further. And we are able to look at a whole world of microorganisms, which leads us to the concept of the more holistic way of looking at it, the concept of One Health concept, that looks at all the living creatures in a certain environment or even in the whole world. So this leads us to a definition. One of the definitions, I have to say there are a few definitions for microbiome, but this is a definition published in 2020 from the journal Microbiome that talks about a characteristic microbial community occupying a reasonable, well-defined habitat, which has distinct physiochemical properties. So microbiome, different from microbiota, which is just the organisms, also talks about the habitat itself and its physiochemical properties. You can see that in the physiochemical properties, we also have microbial structures, metabolites, and other genetic elements such as phages, viruses, and relic DNA. So it's more sort of holistic than just the microorganisms themselves. And the microbiota includes microorganisms from all kingdoms, such as bacteria, fungi, algae, etc. But sometimes we need a more simplified and more technical definition. So this is another definition that they found. The microbiome is defined as the combined genetic materials of all microorganisms in an environment. And this is taken from the European Respiratory Review 2019. So what about the microbiome in bronchiectasis versus the healthy lung? We have a few changes in bronchiectasis lungs compared to healthy lungs. First of all, we have a loss of variation in the microbiome, which includes loss of richness and loss of evenness, which I'll shortly explain. Also, we have predominant species that we see in bronchiectasis patients that are different from healthy lungs. And many times we have infection and chronic infection, and we have to understand what is infection as compared to colonization. And I'll also say a few words about that. So this slide demonstrates the concept I showed in the previous slide. On the right-hand side, you can see a diagram showing the loss of richness and loss of evenness. So if here we have a healthy microbiome with a lot of different microorganisms and all of them in about the same amount, there isn't a certain pathogen that's more abundant than the others. When we have a loss of richness, we have less species, so you see less colors here. And when we have a loss of evenness, that means that one species takes over and becomes more abundant than the others. And these two together cause a loss of variety, which is an important change in bronchiectasis compared to healthy lung. And here in the middle, we can see the predominant species in bronchiectasis. So we can see on the top cultures from a European cohort showing a large proportion of Haemophilus influenza growth, also of Pseudomonas aeruginosa growth. In the middle, we can see growth from a cohort from the United States, an American cohort, also showing a very large proportion of Pseudomonas aeruginosa. And on the bottom, we can see a hypothetical diagram based on a lot of published data that's showing sort of a hypothetical, the whole world bronchiectasis microbiome, also with a large proportion of Haemophilus. This is Pseudomonas, Streptococcus, and other bacteria as well. So this leads us to our second question. So you have a 64-year-old female patient with chronic cough. On a CT scan, you can see bilateral lower lobe bronchiectasis with some tree bud micronodules. Would you try to sample her lung microbiome, and how? Please choose one of the answers.
So I see now, Raya, that some of the options here are or the first option is just not sending any cultures in the first place, but starting with lung clearance and just then sending cultures.
Mm-hmm.
So this is one option, and so we'll see the results soon on what the participants are voting.
Okay, so Michal and Dot, would you like to comment on the answers of the poll?
So I think most will send regular and mycobacterial cultures, and or or do a bronchoscopy, and just a very small minority voted to start with lung clearance and cultures only for mycobacteria.
Yeah, a definite majority thinking that we want some kind of culture, isn't there? I think so. We need to understand a bit more about the microbiology that's going on inside the lung.
Yeah.
Okay.
Although I think if you see a patient for the first time and you just start airway clearance, I think it's really reasonable to send cultures, but it may be changing in the future if she really clears her lung well.
Maybe not send.
I do send.
I would,
Yeah,
I would
yeah,
definitely
me
say,
too, me
yeah,
too.
yeah. I
Well,
think
I agree. I agree with the answers. I would send some kind of a culture.
Wait, so Dot, what do you
you know,
think?
no, I definitely agree, and I think obviously with this kind of question, I think it would clearly be the right thing to start doing some lung clearance treatments, wouldn't it? So I think
Yeah.
that path is clearly a good idea, but
Yeah.
I would definitely also be sending the cultures rather than waiting. So like you say, you want serial cultures, so definitely lung clearance too, but with some microbiology, definitely.
Okay. Okay, great. So let's talk a few words about the microbiome testing. So we have two issues that I want to discuss. One is the sampling method, and the other is the workup method. So for the sampling, we can use two major methods, that is spontaneous expectorated sputum or bronchoscopy. There is also induced sputum after a hypertonic saline inhalation, which I didn't write here, but these are the main ones. So what are our advantages with spontaneous expectorated sputum? First of all, it's very accessible. Usually most of the centers have all the facilities and equipment needed to do that test. It's very easy, it's very quick, it's non-invasive. But we also have some problems with this sampling method. First of all, is it from the lung? Even if it does come from the lung, it can very frequently be contaminated from upper airways, and sometimes it can only be upper airway secretions or saliva, and then it wouldn't give us the right result. So many times the lab returns us the answer of how many epithelial cells and how many leukocytes are there. So we can see if it looks more like saliva with more than 10 epithelial cells, or more like sputum with less epithelial cells and more leukocytes. So that's one problem. And another is that many of our patients don't have sputum to expectorate. They just can't do it. And then it's difficult to sample. And about bronchoscopy, so it's probably more specific than sputum, less contaminated, but it can still be contaminated from upper airways and not always show us the real pathogens of the lung. And of course, it's an invasive procedure with much lower availability and much higher costs. So usually we use bronchoscopy for more, not in all cases, definitely not for all patients, only in specific cases. If we need sampling, if we need more specific sampling, or if we need sampling in a patient that doesn't expectorate. What about the workup method? So we can send our sample for the classic culture. Very accessible, very common test. The problem with this test is usually it shows us only part of the pictures. It shows us the bacteria that grow easily in culture. Other bacteria that are more fastidious might be there in the lung or in our sample, but they will not grow in culture, and we will never know that they're there. An important thing to say about classic cultures is that they're very validated for some pathogens with a good clinical correlation. So we know that if a certain pathogen grows on a classic culture, what does it mean? What's the clinical correlation of it? The other way we can look at the sample is with molecular methods. So first of all, these tests are usually less accessible. Not all labs can do molecular tests on our sample. They could give us more detailed results and also identify organisms that we cannot identify with a culture. They are much less validated for clinical use, and today they're still used mostly in research. I want to add another point to the molecular methods that I didn't write here, is that molecular methods can detect organisms that are not alive. So if we have an organism that we have treated and is now not alive, still parts of its DNA can stay there and come up as positive in the molecular methods. And what about the question is, when we have a pathogen in the culture or in any other method, is it a chronic infection or is it a colonization, and what is the difference? So we don't have formal definitions of chronic infection or colonization, but we should ask ourselves, does this organism cause chronic lung damage? Does it increase the risk of exacerbation? Or is it merely a marker of the disease? Or is it a consequence of the antibiotic use and not a cause of the disease, or a consequence of the change in the morphology of the lung and the airways? But the most important question, finally, we need to answer is, should we treat this pathogen or chronic infection? So some of the organisms that are very frequent in bronchiectasis lung and frequent and significant in the bronchiectasis lungs, I want to talk about a bit more in detail. And those are Pseudomonas aeruginosa, Haemophilus influenza, which is very common, NTM, non-tuberculous mycobacteria, that can be both an etiology and a complicating infection. About viruses, I just want to say that some viruses have been found in higher abundance in bronchiectasis lungs, but we're still not sure, and there's not a lot of evidence of their significance. So I will not talk about viruses. I will say a few words about fungi and changes in the microbiome, and just a few words about changes during exacerbation. This talk is about stable bronchiectasis, not about exacerbation, but I will say that most of the data point to the fact that there is not a lot of change or no significant change between steady state and exacerbation regarding the microbiome. Michal and Dot, if you want to add anything, please feel very free. This is this slide is taken from the EMBARK registry, showing the different bacteria that have been seen in the cultures of bronchiectasis patients. So we can see a very large proportion of Pseudomonas aeruginosa. After that, of Haemophilus influenza, and then other bacteria. And on the bottom part, we can see that in different sites or different countries, the frequencies were different, but almost all of them had a very high frequency of Pseudomonas aeruginosa. So this seems to be a very important pathogen. And we do know about Pseudomonas that a chronic infection in bronchiectasis is related to increased morbidity, including exacerbations and hospitalizations, and also increased mortality. In a large cohort of patients of over 2,500 patients, there was a correlation found to mortality. You can see it clearly here in the graph. So patients with the growth of Pseudomonas have a higher rate of mortality. And of course, this is very important. So this is a very major important pathogen in bronchiectasis. What about Haemophilus? So he's also a very abundant pathogen. I mean, But chronic infection with Haemophilus is less associated with morbidity and mortality. A cohort study published in 2014, the Bronchiectasis Severity Index study, showed that any chronic infection with many pathogens, including Haemophilus, was associated with morbidity, but not mortality. Another large retrospective study from South Korea showed, first of all, a much much smaller percentage of Haemophilus growth, just 1.8%, which is much less than the European cohort. And they showed that it was associated with disease severity and mild exacerbations, but not mortality and not severe exacerbations. So I want to say, conclude about Haemophilus that, first of all, it's a common pathogen, although with very large geographic variability. So it's very different in different parts of the world, unlike Pseudomonas that is common in all cohorts. But it is common in many cohorts, and I think we need more research to understand the role of Haemophilus in bronchiectasis. I think we don't know enough about Haemophilus.
Maybe I can stop here for a minute because you mentioned the bacteriology of exacerbations, and I want to remind the audience that we had a webinar dedicated to exacerbations and the cause, and you can access the recording on the web page of Embark and ELF. And it was our colleague, Dr. Sivan Pearl, talking about exacerbations and their microbiology. So it's a different topic. Of course, I think Raya will not go into that today, but there's a lot of things to be said about exacerbations, of course.
Yes, of course. Okay, so I want to say a few words about non-tuberculous mycobacteria. They can be a cause of bronchiectasis and were described as a cause in about 1% of patients in the Embark registry. And they can also be an infection related to bronchiectasis or complicating bronchiectasis in considerable amount of patients, in about 10% in meta-analysis. But with a lot of variation. So in the United States, they were described as a complicated infection in around 40% of patients. So there is really a huge variation, with the most common species being Mycobacterium avium complex, 77% in a meta-analysis. I will say in the same meta-analysis, Mycobacterium simiae was the second, which I think does not represent most of the world, because Mycobacterium simiae is very specific to certain parts of the world, including Israel, for example, but I don't think it represents most of Europe. In the American registry, I'll just add, with a 40% Mycobacterium in general, they described just MAC, Mycobacterium avium complex, and Mycobacterium abscessus. They didn't talk about any other species. So I suppose those are the two main ones in the United States. What about fungi? So fungi are a much less known kingdom than bacteria, still, I think, to most of the medical fields. We do know that there is a change in the microbiome, that means in the community of fungi in bronchiectasis patients compared to healthy individuals, and that they are dominated by different species of Aspergillus, Cryptococcus, and Clavispora, and most importantly, Aspergillus. Why did I highlight Aspergillus? Because we do know that Aspergillus can be related to certain disease entities, which include, for example, ABPA, allergic bronchopulmonary aspergillosis, which is actually an allergic sensitization to Aspergillus. And it can also be related to chronic cavitary pulmonary aspergillosis and other chronic infections with aspergillus, but this is a much rarer disease entity which we don't see much, and usually happens in mildly immunosuppressed patients. But it is worth remembering that, yeah, aspergillus is common in bronchiectasis. It can cause sensitization, and we should be aware of that and always have ABPA in our mind. So this is also relating to the previous slide. This is a microbiome in a few cohorts, in a cohort from Singapore, Kuala Lumpur, and Dundee, compared to healthy individuals, non-diseased individuals, and we can see they all had a lot of candida. That's the dark green, which we're not sure. We don't know what significance of candida in sputum cultures. Usually we don't do anything with candida, but we can see that the bronchiectasis cohorts had a lot of aspergillus compared to healthy individuals which didn't have it at all, and I think this is very important. Okay, so what are the interventions we can do for our patients regarding the stable microbiome? So we'll talk about three major interventions, and that is eradication of Pseudomonas aeruginosa, treatment of non-TB Mycobacteria pulmonary disease, and chronic antibiotic therapy. Oh, sorry. Okay, so I'd like to continue to another question. If we can have the poll, please. Thank you. So your patient with bronchiectasis gave sputum for culture, and it grew Pseudomonas aeruginosa. What would you do? Please choose one of the answers.
So the question is admitting to hospital for IV. It's usually a chronic infection. I'll treat only if symptomatic. I'll try or an oral eradication protocol, or send another culture. I'll treat with if 2 cultures are positive. And I'll just maybe add complexity to this question and saying that when we see a patient for the first time, and I know that many of our patients have been symptomatic for a long time before ever coming to care and giving a sputum sample, it's really hard for us to tell just sending the first sputum sample if, for example, it's Pseudomonas, how old is this Pseudomonas in the lungs?
Yeah.
If we don't have a previous in a culture, we will never know.
Yeah, very important point.
Okay, so we have the results. So Raya, do you want to say anything or Dot about the results of the poll? I think a little more than half of the respondents would try an oral eradication protocol.
Yeah, and then a kind of fairly even split, isn't there, amongst the other options in terms of admitting to hospital or only treating. I mean, I guess for me, it kind of highlights the complexities. Even without Mikal, your additional complexity of not knowing how long the Pseudomonas has been there for. And I know Mikal will go through some of this, but I guess the evidence is quite patchy, isn't it? So in terms of what to do, with this, so I think that does reflect some of this. But what you've clearly shown, haven't you, Mikal, is that it is a problem. Pseudomonas, we know it's a problem associated with morbidity and mortality. So certainly, we would be keen to try something to try and get rid of it. So some form of eradication protocol, and then there are the complexities of what that might look like. I think, given the information you've given, I would have probably opted for C. I'd have gone for A if they were unwell, you might want to admit them for IVs. But I think if they were well and that was just a positive culture, I'd have plumped for C, plus or minus some extra.
Yeah. Yeah, I suppose I would too, but yes, I really understand how the other answers also make sense. I want to say regarding the last answer, if that is wait for another culture, that it's true that we diagnose chronic infection in any pathogen is at least 2 cultures usually. But when we get Pseudomonas, really, usually for me, 1 culture is enough to do something about it because it's such a bad pathogen, as we know.
Yeah, I agree, and I think that the guidelines do mention this option and to just validate this with another culture, but I think it's tricky because if you get a second culture in a very short time, I think you would definitely treat. But what if you don't? What if the second culture comes back negative? How sure are you that there's not Pseudomonas in there somewhere?
Yeah, I totally agree. But a kind of very low threshold, I would say, for trying to eradicate.
All right, so eradication of Pseudomonas aeruginosa. So definitely eradication attempts at first growth is recommended by most guidelines by the British Thoracic Society and the European Respiratory Society. And we have different protocol options. I think we all use very different protocols, and we have different attitudes towards towards the eradication and how aggressive we need to be about it. So both guidelines offer a few protocols, a few possibilities. So we have the options of oral therapy, we have the options of IV therapy, both systemic, of course, and we can use combination of systemic therapy, and we can add inhaled antibiotics in the beginning of the protocol or as the continuation phase of the protocol. So we really have a lot of options. Of course, it also depends on the pathogen itself, if, for example, it's resistant and so on. So what are the results of the eradication? It's true, we want to get rid of it, but does it really work? So we look at I look at 3 results, and that is successful eradication in terms of microbiology, clinical benefits, and is there a better protocol? So in terms of microbiology, in a meta-analysis published very recently in 2024, about 40% of patients receiving eradication were free of Pseudomonas at 12 months. So 40%. That's not very good. What about the clinical benefits? We have less evidence and we have low level of evidence showing benefit, and that is an exacerbation frequency going down and reported clinical improvement. But again, these are lower level of evidence. And what about the different protocols? So in this meta-analysis released recently, it showed that a combined protocol of systemic and inhaled antibiotics was better. We can see it here. The systemic plus inhaled had a 48% eradication as compared to 27% with only systemic antibiotics. So I think this is a very important point that I don't know if we all start with a combined protocol, which is sometimes requires much more work and a lot of effort from the doctor and from the patient to start with a combined systemic and inhaled antibiotic protocol, but it seems that it is very important. I just want to say that this trial, the ERASE trial, is now going on, and it's a trial testing the efficacy and safety of tobramycin inhalation preparation. And another important thing in this trial is that it will test the clinical outcomes as well as the microbiological eradication rates. So I think when it ends, it will give us a better idea about how important or what are the outcomes of good eradication. Okay, so we'll go on to question number 4 regarding non-TB mycobacteria.
So I think there were people with raised hands. Oh, maybe we'll do it after the poll. Okay, so sorry, go on.
Okay. So the eradication treatment for Pseudomonas was successful for your patient, but your patient had a growth of Mycobacterium intracellulare in 2 separate cultures. What is the next step? Please choose one answer.
Shall I run through the options for this one, Michal? So that the options
Yes,
you've
please.
got are so we could start treatment for the intracellulare immediately, since a delay reduces the success rate. Or we could wait and see what we think about the patient's symptoms. It depends on the patient's symptoms. Number 3, maybe the intracellulare is considered to be less pathogenic, so treatment not necessary. And then the last one, treatment's long and complicated, so only treating if they've got more advanced disease, so cavitary disease.
So maybe if people have voted, we can already see the polls.
Okay.
And so the majority this time wanting to see what the patient's symptoms are, but quite a high number also thinking that they might want to start treatment immediately, since delay might lead to less success, a higher failure rate, and then a kind of couple of people voting for the other options. So treatment not being necessary, or only doing it if it's severe disease. So I think patient symptoms are going to be definitely relevant here, aren't they? I mean, I think obviously there's a whole combination of things to think about with NTM. It is complicated, I guess, would be the first thing I would say. It's definitely complicated trying to pick it apart. Yeah. But I think patient symptoms are definitely relevant in terms of trying to decide if this intracellulare is actually a problem, or just a kind of bystander would be where I would.
And how big a problem as well. Yeah. Before we start the journey of treatment.
Good description. Journey.
Yeah. And I think the key here is also how sure we are that we've managed in eradicating Pseudomonas, because it's really difficult, as Dot was saying, to differentiate. Is it the Pseudomonas causing the symptoms, or the intracellulare causing the symptoms? So it's very difficult. If we're really sure that we no longer have Pseudomonas, and a long enough time has passed and the patient is very, very symptomatic, then I think it will be moving us to treat the intracellulare.
I think it's a very good point, and I think sometimes, we have our patients with mycobacteria, and we follow them, and then we forget from time to time to test the other pathogens and see if they're deteriorating because they grow Pseudomonas or something else again, and it's not the MAC at all. So that's a very, very important point. Thank you.
Totally agree.
Yeah, so just can I remind people, I think we saw some hands up, but it's probably better to post comments or questions in the chat, and then we'll get to these at the end.
So before deciding to treat mycobacteria, first of all, we have to diagnose an NTM pulmonary disease, and for that we need to see if we meet all criteria for the diagnosis, and those are symptoms, imaging that is that is what we see in mycobacteria, and that we have two cultures of the same pathogen. So if we have two cultures with two different pathogens, then it's not considered a diagnosis of NTM pulmonary disease. So that's a very important point. So we definitely need symptoms, and we definitely need imaging. And even if we have all of those criteria and we did diagnose NTM pulmonary disease, we don't always treat the patient. We have to consider what is our risk-benefit ratio for this specific patient. So we have to think of a few parameters when we decide what's larger, the risk or the benefit, and we have to look at the pathogen itself and see if it's considered, if it's a known pathogenic mycobacteria. Also, of course, the host characteristics, the age, comorbidities, etc. And also the disease characteristic, how extensive is it? Is it cavitary or non-cavitary disease? When we look at a cohort of patients, or when a cohort of patients was published, they saw that the disease was progressive in 60% of the patients, leading to treatment. But in the other patients, 25% had a static course without treatment, and half of them had a spontaneous sputum conversion. So we do have to keep in mind these numbers and know that it doesn't always lead to progressive disease, and we have to really consider all the parameters. And what about the success of the treatment? So it's very difficult to determine, and we don't have very significant evidence showing benefits, clinical benefits for treatment, unfortunately, still today. Regarding microbiologic success, there also the treatments are not very successful. In a large American registry, they have shown that, first of all, around 40% of the patients were not treated. The ones that were, usually the treatment was delayed over 90 days between the growth and the start of the treatment. So I think it goes to show that really many physicians feel that they need to see if the disease is progressive before starting treatment. The clinical outcomes were described, but it wasn't a large enough cohort, and they didn't analyze it statistically at all, if the clinical outcomes were better with treatment or not. And regarding the microbiology results, in MAC, 27% of patients had cure, but 29% had failure of treatment. So they didn't eradicate their MAC. And in Mycobacterium abscessus, numbers are more or less the same. So we see it's really difficult to treat NTM. And we'll go on to our last question. And if we could have the poll, thank you. When would you consider chronic antibiotic treatment for your patient? So I'll read the answers. Only for chronic Pseudomonas infection. In any chronic infection, if the patient is very symptomatic. In patients with recurrent exacerbations, or in patients with recurrent exacerbations only with chronic Pseudomonas infection.
So I think this question really deals with both inhaled and oral long-term antibiotic treatments, right?
Yes, of course.
So
yes.
both
Yeah,
types.
okay.
Okay.
So yeah, we can see the results of the poll. Okay. Great.
So again, we got a majority, haven't we, going with recurrent exacerbations?
Yes. Yes.
Regardless of micro. And then also, yes, some who are going for very symptomatic. to me, a lot of this one comes down, doesn't it, to what you think is driving your bronchiectasis. I guess it's that idea that we think the exacerbations are what's driving progression of your lung damage, don't we? I think the second one actually is also interesting. Chronic infection if the patient is very symptomatic. I guess it's whether or not we feel those very symptomatic, are those symptoms being driven by untreated bacterial load, isn't it? So I think number two is an interesting question.
Yes,
Whereas number
I
three
agree.
perhaps is a bit more I guess what we're all guidelines based and to do with what we think the exacerbations are doing to the underlying disease. I don't know what you both feel.
I feel that it's much more difficult to look at and test and research the second option of a very symptomatic patient, not only in bronchiectasis, but we see that also in other lung diseases. So it's a result that it's much more difficult to see if it helps a very symptomatic patient.
Yeah.
And sometimes it's even difficult to say or see the difference between a chronically symptomatic patient and a recurrent exacerbator, because where do you put the line is also a question. Where does the patient put the line between an exacerbation and just being very symptomatic all the time?
Yes,
So,
and sometimes exacerbations are not really identified. But I think I would agree with the second option, treating with it if very symptomatic, with being macrolides, because they also have or presumably have an anti-inflammatory effect. So even if there's no chronic bacterial infection, but still there's some inflammation going on, neutrophilic inflammation going on, then probably there is some benefit for macrolide regarding of infection. So I would agree with the second and the fourth options.
yes, I also agree. Perhaps also with chronic Pseudomonas and very symptomatic patients, even not perceiving themselves as a recurrent exacerbator, I might try some chronic antibiotic treatments. All right, so what do the guidelines tell us? So here we have a diagram taken from the European guidelines from 2017. So here, for patients with 3 or more exacerbations per year, we should start thinking about chronic antibiotic treatment, of course, after optimizing all the other treatments, airway clearance, and underlying causes. And in these guidelines, if a patient has chronic Pseudomonas infection, we would go for long-term inhaled antibiotic, and if they don't, we would go for long-term macrolide antibiotic treatment, and we can switch between those treatments or combine them in case that it's not enough. I want to emphasize that it's very important to rule out NTM infection before we start using a macrolide antibiotic chronically, because we can cause a resistant NTM, which is much, much more difficult to treat. So what are the evidence for this? So regarding inhaled antibiotics, we can use colistin, aminoglycosides, and more recently other preparations have been tried, such as aztreonam, ciprofloxacin in a special inhalation preparation. Overall, all of these had only modest results, mostly reducing severe exacerbations. Macrolides, however, did have better results. There are 3 large randomized placebo-controlled trials with macrolide antibiotics that have shown benefit, reducing exacerbations, I think, mostly. And other systemic antibiotics, such as amoxicillin and ciprofloxacin, have been tried in a very small number of patients. They had some good results, but these are very, very low level of evidence. So I think also lately, I think it has been shown, I didn't include it in the presentation, that also in patients with Pseudomonas, trying chronic macrolides first might be a better choice than inhaled antibiotics. But it's still not included in guidelines. All right, so to conclude, I would like to just repeat the main, most important for me, take-home messages from this presentation. And these are that the microbiome in bronchiectasis is different from healthy lung. And knowing our patient's microbiome is important and is crucial for good clinical practice and outcome of our patients. Routine sputum cultures are cornerstone in our management, and we should remember and do them routinely. Pseudomonas aeruginosa growth changes prognosis and management of our patients, and eradication should be considered. Anti-M growth can also change the prognosis and management of our patients, and treatments should be considered, of course, in the right clinical situation. And chronic antibiotic treatment is beneficial in recurrent exacerbators and should be considered as well. So thank you very much for listening, and the session is open for discussion.
So Raya, thank you so much for this wonderful talk. And I see a really interesting question in the chat about hypertonic saline, and of course it's being has very good outcomes with quality of life. And the question is it also bactericidal or bacteriostatic, or can it help us get rid of bacteria? So, Raya, do you want to have a go, and then Dot maybe?
Yeah, sure. I think it's a very interesting question. I don't know if there is evidence about bactericidal or bacteriostatic effects of the hypertonic saline, but I think, like I started my talk, and in talking about the microbiome, we have to understand that there is interconnections between all the parameters that are part of the microbiome. So if we're helping the secretions become less, sticky, and the patient is able to clear their lungs more efficiently, then it also has an effect on the infections. Of course, it's not separated. It all goes together.
Yeah, I don't think I've got anything to add to that really. I mean, and certainly the question obviously was kind of specific about data. I'm definitely not aware of, if either of you are, but I'm not aware of any data to say that it changes it. And I totally agree.
Yeah. So I'm aware that we only have about a minute left. So Raya, can you advance the slide?
Yeah,
and
sure. Sorry.
And yeah, so it's just time to mention the two next webinars in this series. The next is on airway clearance, with the discussant being Arietta Spinou from London. And the last one in this series would be the radiology of bronchiectasis. And so the recordings of the previous webinars can also be viewed. And thank you very, very much.
Thank you. Thank you both, and thank you for everybody listening, and thank you, Kara, for helping us to organize all this.
Absolutely.
Yeah.
I agree. Thank you.
So I realize there's some questions, but we don't have any time, so I'm sorry. And thank you everyone for listening, and for Raya for giving a wonderful talk, and Dot for being such a wonderful discussant. So thank you all.
Thank you.
Thank you.
Thank you. Goodbye.
Bye everyone. Bye.